Welcome, future surgeons. We're doing a high-yield explainer on one of the most critical skills you will ever master, how to handle transfusion in a bleeding patient. We're going to cut right through the noise and focus on what you absolutely need to know to be a safe surgeon, and of course, to crush your exam. So, let's just jump right into it. Picture this, a high-stakes scenario that you are absolutely going to face. The lights are bright, the pressure is on, every single second counts. And listen, this is not just some theoretical thing. This is the very core of what we do. Okay, so meet our patient. This guy is in class 4 hemorrhagic shock. What does that mean? It means he's lost over 40% of his blood volume. That heart rate of 140, that's his heart just desperately trying to keep up. And that positive FAST exam tells you his belly is absolutely full of blood. So this is our anchor case. Every single decision we make from this point forward is for him. All right, let's think like surgeons together. You've kicked off damage control resuscitation, right? Your whole strategy is to stop the bleeding, fix the immediate threats to his life, and get out of the OR fast. But what's in that cooler that's on its way? What are you specifically ordering, when you're giving it, and most importantly, why are you giving it? These are the questions that literally change patient outcomes. So here's our game plan to take this patient from total crisis to under control. We're going to start with our tools, then we'll hit the critical numbers, learn how to fix the clot, escalate our response, dodge complications, and then we'll wrap it all up with a rapid-fire review. Let's get into it. Okay, Section 1, the patient and our toolkit. Look, before we can fix the problem for our guy, we have to know our tools inside and out. Each blood product has a really specific job to do in rebuilding his ability to clot. This right here is your arsenal. You've got packed red blood cells. Their job is to carry oxygen. Platelets, they form that initial plug in the hole. Fresh frozen plasma, or FFP, is like this soup of all the enzymes you need to build a fibrin scaffold. And cryoprecipitate? Think of that as the concentrated clot glue, mostly fibrinogen, that makes the whole thing strong. And whole blood? Well, that's the original, perfectly balanced resuscitation fluid. Knowing what each of these does is step 1. Now for the numbers, the thresholds that are going to guide our every move. You know, in surgery, we always say we treat patients, not numbers. But these specific numbers, they're based on some really high-level evidence, and they tell us when a patient's physiology is failing and they need our help. High-yield Pearl Alert. This super simple rule, based on the latest AABB guidelines, is going to save lives and score you points. For most patients who are hemodynamically stable, we stick to a restrictive trigger of 7. Why? Because the body's actually pretty amazing at compensating. But for a patient with known heart disease, we use a threshold of 8. Their heart just doesn't have the reserve to pump faster to make up for anemia. And what about a patient who's having an active heart attack? Well, the MINT trial data suggests we should aim for a more liberal target of 10 to protect that struggling heart muscle. You have to memorize this ladder. These are the 2025 international guidelines for when to give platelets. If they're below 10,000, you're worried about a spontaneous bleed in their brain. Below 20,000 is the newer, more restrictive threshold for things like a central line. 50,000 is your go-to number for most major surgeries. But for the brain or the back of the eye, we're talking closed spaces where even a tiny bit of bleeding is a total disaster. You need at least 100,000. So now that we've covered the solid parts, the RBCs and platelets, let's talk about the liquid factors that actually build the clot. So now we're in Section 3. And we're totally focused on making a stable clot. It's not enough to just plug the hole with platelets, right? You need the entire coagulation cascade. And that's fueled by products like FFP and cryo to build a durable fibrin clot that's gonna last. Okay, what's really interesting here is how this slide contrasts your options for fixing coagulopathy. FFP is what you grab when you have a really broad deficiency, like in liver failure or, a massive transfusion. Cryoprecipitate, on the other hand, is a precision tool. You use it specifically when fibrinogen is low, usually below 150. And here is a classic board trap. Cryo is also your source for factor 13, that's the final clot stabilizer. And whole blood? It is making a huge comeback because it delivers everything in its natural concentration, and get this, those cold-stored platelets are actually more hemostatically active right out of the bag. Let's get back to our patient from the beginning. He's still bleeding, his vitals are not getting better with the first few units of blood. It is time to stop thinking in terms of single products and escalate to the massive transfusion protocol, or MTP. Do not wait for labs. Seriously, they are 45 minutes behind what's actually happening to the patient. A clinical score, like the assessment of blood consumption, the ABC score, tells you to activate MTP immediately. Our patient has a penetrating mechanism, a positive FAST, a systolic pressure under 90, and a heart rate over 120. His score is a 4. You should have activated the MTP the second he rolled through the door. So, why do we activate? What's the big deal? It's because of evidence like this. The landmark PROPER trial proved that a balanced 1:1:1 ratio of plasma, platelets, and red blood cells is the absolute standard of care for damage control resuscitation. Plain and simple, you get the patient to stop bleeding faster, and you reduce deaths from exsanguination. This is why MTPs exist. But look, those blunt ratios are just the start. They're for the initial chaos. Once you start catching up, viscoelastic testing like TEG or OTM lets you do goal-directed precision resuscitation. It gives you a real-time picture of the entire clotting process. And this right here brilliantly shows how to turn a really complex tracing into 4 simple actions for our patient. If the R time is long, it means clot initiation is slow, the patient needs factors, so you give FFP. If the alpha angle is narrow, the clot isn't building fast enough, that's a fibrinogen problem, so you give cryo. If the maximum amplitude is low, the final clot is just weak, that's a platelet problem. And if LY30 is high, the clot is breaking down way too fast. That's hyperfibrinolysis, and the answer there is tranexamic acid or TXA. Simple. So, we're stabilizing the patient, the bleeding is finally slowing down in the OR, but our job is not done. Not even close. Now, we have to anticipate and prevent the secondary threats that come from the massive transfusion itself. Okay, board trap warning. Confusing these 2 common lung injuries is a classic mistake. So the patient becomes hypoxic. You get a chest x-ray and it has bilateral infiltrates within 6 hours of a transfusion. Is it TRALI or TACO? The absolute key is the blood pressure. TRALI is an inflammatory, leaky capillary kind of edema that causes hypotension. TACO is just simple volume overload, causing hypertension. You treat TACO with diuretics. If you give diuretics in TRALI, you will only make the hypotension worse. You know, we all learned the lethal triad of trauma. Well, now it's the diamond of death. The 4th point is hypocalcemia. The citrate that's used as an anticoagulant in blood products, it binds up all the ionized calcium. And what does calcium do? It's absolutely critical for the coagulation cascade and for cardiac contractility. So when you're giving massive amounts of blood, you have to proactively replace that calcium. A really good rule of thumb is to give 1 gram of calcium chloride for every 4 units of blood products you hang. So, we've managed the crisis. Our patient is stabilized, the bleeding is controlled, and we've avoided the major complications. Now, let's just lock in the key takeaways for your exam and for your next trauma call. This is it. If you remember nothing else, remember this slide. Let's just run through it real quick. RBCs, 7 for most, 8 for a cardiac history, 10 for an active heart attack. Platelets, remember that 10, 20, 50, 100K ladder. MTP and ABC score of 2 or more triggers a 1:1:1 ratio. TEG, R time gets FFP, a narrow angle gets cryo, low MA gets platelets, and high LY30 gets TXA. Cryo is for fibrinogen under 150, and don't forget it has factor 13. Hypocalcemia, the 4th point in the diamond of death, give calcium chloride. TRALI versus TACO, TRALI is hypotension, TACO is hypertension. TXA, give it within 3 hours of injury, and for warfarin reversal, 4-factor PCC is your first line, not FFP. That's how you show you know what you're doing and keep your patient safe. So what have you really done here? You didn't just pour blood into someone. You took a patient who was on the brink of death from a gunshot wound, and you performed a targeted metabolic rescue. You used evidence to guide every single step, from hitting the MTP button to precisely fixing his coagulopathy with TEG and preventing the diamond of death by giving calcium. You know, safe surgeons don't just know the answers, they prevent disasters before they happen. Hey, thank you for joining this explainer. Study smart, be safe out there, and we'll see you for the next high-yield dose.